Welcome to this comprehensive overview of the pathogenesis of rheumatic heart disease and mitral stenosis. Despite advances in modern medicine, rheumatic heart disease, or RHD, remains a leading cause of cardiovascular mortality in children and young adults globally, particularly in developing nations. According to the latest guidelines from the World Health Organization and the American Heart Association, understanding the complex interplay between host immunity and bacterial infection is crucial for both prevention and management. Today, we will explore the intricate mechanisms that begin with a simple throat infection and culminate in severe structural damage to the heart valves, focusing specifically on mitral stenosis. The journey of rheumatic heart disease begins not in the heart, but in the pharynx. The initial trigger is an infection by group A beta hemolytic streptococcus, commonly known as strep throat. This bacterium possesses several virulence factors, but the most critical for RHD is the M protein, which forms an alpha helical coiled coil structure on the bacterial surface. Another key component is the group A carbohydrate epitope, N-acetyl beta-D-glucosamine, or GLC-NAC. In most individuals, the immune system clears the infection without long-term consequences. However, in genetically susceptible individuals, comprising about 0.3 to 3% of those infected, a misdirected immune response occurs. The cornerstone of RHD pathogenesis is a phenomenon known as molecular mimicry. The bacterial M protein and GLC-NAC epitopes bear a striking structural resemblance to endogenous host proteins. Specifically, they mimic the alpha helical coiled coil structures of cardiac myosin, laminin, vimentin, and tropomyosin. Because of this similarity, the antibodies and T cells generated by the host to fight the streptococcal infection become confused. Instead of exclusively targeting the bacteria, these cross-reactive antibodies mistakenly bind to the host's own tissues. This loss of self-tolerance leads to an autoimmune attack on the heart, initiating acute rheumatic fever. It is important to note that a single streptococcal infection rarely triggers the full clinical spectrum of RHD. Instead, the disease is driven by repeated infections, a process termed immune priming. With each subsequent exposure to group A streptococcus, the immune system's germinal centers maintain and amplify the reaction. Pre-existing immune complexes capture more immunoglobulins, leading to a robust and amplified autoimmune response. This repeated immunological insult progressively breaks down immune tolerance, shifting the balance from a protective response to a destructive autoimmune cascade. While acute rheumatic fever can cause pancarditis, inflammation of all three layers of the heart, the damage to the myocardium and pericardium is typically reversible. The permanent, devastating injury occurs primarily in the valvular tissue, most commonly affecting the mitral valve. The damage is initiated when circulating autoantibodies, particularly IgG2 subclass antibodies against the GLC-NAC epitope, bind to the valvular endothelium. This binding upregulates the expression of vascular cell adhesion molecule 1, or VCAM1. The activated endothelium acts as a gateway, facilitating the infiltration of CD4-positive T lymphocytes into the valvular subendothelium. As the inflammatory cascade progresses, cytokines like interleukin-1 beta and TGF-beta drive the differentiation of valvular interstitial cells into collagen-producing myofibroblasts. This exposes extracellular matrix components, triggering the production of anti-collagen antibodies, which further fuel the pro-inflammatory environment. Over years or even decades, this chronic, smoldering inflammation leads to profound structural changes. The mitral valve leaflets become thickened, rigid, and fibrotic. The commissures fuse together, and the chordae tendineae shorten and thicken, severely restricting leaflet mobility. This structural distortion results in mitral stenosis. A normal mitral valve orifice measures 4 to 6 square centimeters. As the area narrows to less than 2 square centimeters, it creates a significant impediment to blood flow from the left atrium to the left ventricle. This hemodynamic bottleneck causes an increase in left atrial pressure, which is subsequently transmitted backward into the pulmonary vasculature, leading to pulmonary hypertension. As the left atrium dilates under chronic high pressure, the patient faces a high risk of developing atrial fibrillation. The loss of the atrial kick during diastole can precipitate sudden congestive heart failure. According to the 2020 American College of Cardiology and American Heart Association guidelines, the severity of mitral stenosis is classified into stages based on valve anatomy, hemodynamics, and symptoms, with severe stenosis defined as a valve area of less than or equal to 1.5 square centimeters. Furthermore, the 2023 World Heart Federation guidelines emphasize the critical role of echocardiography in the early detection of these morphological changes, allowing for timely intervention before irreversible heart failure occurs. In summary, the pathogenesis of rheumatic mitral stenosis is a tragic consequence of molecular mimicry, where the body's defense against a common bacterial infection turns against its own heart. Through repeated infections and chronic inflammation, the delicate mitral valve is transformed into a rigid, stenotic barrier. Understanding this complex autoimmune mechanism remains essential for developing better preventive strategies, such as vaccines, and for guiding clinical management to reduce the global burden of rheumatic heart disease. Thank you for watching.